Okay, so this presentation I'm gonna do it in English because everything is in English, here, and there's no point in me of like going back and forth. I mean, you guys are, interns, and I hope this is something that helps people that come here, or even people in Brazil, who are seeing patients in the ED. So I'm gonna go over some practicalities in hemodynamics. Again, since we're going to release this, I have no conflicts of interest. I'm just a fellow. And I'm going to start, it's pretty much 4 cases that I'm going to discuss. This is the first case. It's a 70-year-old man with hypertension, hyperlipidemia, heavy alcohol, and some mild cognitive impairment who presented to the ER with abdominal pain. In the ER, he was drowsy and confused when roused and peripherally cold with cyanosis. His blood pressure was 75/50, heart rate was 125, and the abdomen was tense and distended. So as soon as he got there, and this is something that you guys need to start playing with, the point of care ultrasound. Every corner in every hospital here in this country, has an ultrasound machine that you guys should become comfortable assessing. And here, every patient that goes to the ER, the first thing that they do, one of the first things that they do, they put a probe. And these are like 2 of the views. I'm going to go over in more detail in some later slides. But here, you have 2 basic views. One is what they call like a parasternal long axis views. Don't worry about the terminology. I'm going to go over in detail later. And we see how the heart is squeezing here. So here, as you can see, the probe is here, is up here. And you have like this kind of triangle-shaped, image here, and the echo is a tomographic image. So the first thing that you see here, in this view, is the RV or the RVOT, the RV, or right ventricle outflow tract. Going down here, you have the septum. Okay, you have the aortic valve, and then you have the left ventricle. Okay, you see like some of the chordae. You see the anterior mitral leaflet, the posterior mitral leaflet, and the posterior wall. Okay, you see how this heart is squeezing really well. If you get this probe and just turn it like 90 degrees, you're gonna have the parasternal short axis view. You're gonna cut the you see like this little donut here. This is the left ventricle at the level of the papillary muscles here. You see how well it's squeezing. So the guy is coming in. He has low blood pressure. He's tachycardic, but his heart is moving really well. And this is another view. It's called the apical 4-chamber view because you can see like the 4 chambers. You put just below the nipple. You can see how well the heart is squeezing here. Okay, you have like the left ventricle here, more muscular, the mitral valve. You have the left atrium. You have the right atrium. You have the right ventricle, and the heart is squeezing really well. Normal ejection fraction here, I would say at least 60%, but it doesn't matter. Just normal left ventricular systolic function. Okay, here it's a subcostal view of the this is the IVC, the inferior vena cava. Okay, and you see that the vena cava here is collapsible, easily collapsible. It's not distended. Okay, so he's dry. He needs fluids. Okay, and his heart is not the source of the problems. As you can see here. So you can see just by putting a probe on a guy's chest, and this is easy. All of my residents here at Emory, they're able to get those images, okay? This is something that is fairly easy to do. You guys need to become familiar with that. So this guy is dry. He has normal left ventricular function, okay? So what happened with him? So he was given some plasma lights. Plasma light is some kind of fancy normal saline that they have here to restore his blood pressure. His CT scan, abdomen, pelvis show extraluminal gas. Okay, so he has gas in the peritoneum and suspected extraluminal feces consistent with a perforated sigmoid colon. Okay, you guys will see this for sure. So he was started on empiric antibiotics. He got vancomycin, to cover gram-positives, including MRSA, and Zolsine. Zolsine is piperacillin, piperacillin tazobactam. Okay, so it covers gram-negative, including pseudomonas. And he was taken to the OR for an exploratory laparotomy, or XLAP, as they call it here. So the X-lab demonstrated gross fecal peritonitis from a perforated sigmoid colon. He had a Hartmann procedure and some extensive peritoneal toilet and washout. In the OR, he received a total of 4 liters of plasma light. And then he was transferred to the MICU, the medical ICU. He was still anesthetized. He was intubated with mechanical ventilation with a FiO2 of 40% and a PEEP of 6. The arterial blood pressure was supported by levofed. So levofed is norepinephrine, okay? It's a vasopressor. Has alpha and also, a little bit of beta agonistic effects. So when they arrived in the ICU, his vitals were the blood pressure 88/48 with a MAP mean arterial pressure of 56, heart rate 120 in sinus rhythm. His central venous pressure, his CVP was 6, and his temperature was 36.6. His ABG, his arterial blood gas, okay, was showing a pH of 7.32, so mildly acidotic. PCO2 28, PO2 85 with saturation of 99%. His lactate was 3, so mildly elevated. VBG, a venous blood gas, from his central line show a central venous saturation of 75% and a hemoglobin of 14. So what's the mechanism of shock for this guy? Can you guys tell me?
Distributive,
yeah, septic shock, right? Can you guys, based on the information that I have here, estimate, his cardiac output, his cardiac index, and his systemic vascular resistance, okay? Can you do that? I'm not gonna wait too much here. I'm just gonna go over, okay? So based on this information, remember the guy has a line, he has an arterial line, and he has a central line. And look at how much information we can get, from an A line and from a central line. Okay, we can estimate. I mean, it's not going to be super precise because the central line is sitting. Okay, so after here, people usually get the right internal jugular, the right IJ. So usually you put a right IJ central venous catheter over there that sits. At the interface between the superior vena cava and the right atrium, okay? So the venous set, that you're going to get from there should correlate roughly, with the central PA set, okay? But sometimes people have shunts. They have communications, inside of their hearts. So, but for the most part, it usually correlates really well, okay, with the PA sets. So we can use his central venous set, to calculate his cardiac output. And by calculating his cardiac output, we can also use information from his central venous pressure and from his maps, to estimate his systemic vascular resistance. So we do this by using the Fick equation. So the Fick equation, we use the VO2, which is the consumption of O2. We have this constant here. I mean, there's lots of criticism, but usually, for the most part, we use this constant of 125 multiplied by the BSA, and so we can have, the VO2, which is 250, and then we divide that by the arterial venous O2 difference. Okay, so his sats are 99%. Okay, you don't even need like an A line. I mean, you can have the sats from pulse oximeter, here, and roughly, I mean, we can get like, a number of, cardiac output, to make some clinical decisions if you don't have an A line. But the difference here from 99% to 75%, which is the central venous sat, you multiply that difference, by the amount of hemoglobin, that he has, which is 14. And then we have this constant here that is 1.36. And then just, multiply that by 10, we're going to have this number 45. So divide 250 by 45, you have the cardiac output of 5.47 liters, okay? And you divide that by his body surface area, okay, the BSA that I give it here, that is just, based on his weight and height, and you're going to have 2.73 liters per minute per meter square. So cardiac index above 2.2 is normal. Okay, so he has a normal cardiac index. So clearly he doesn't have any, clearly this is not a shock that is from cardiogenic origin. Okay, but what about his SVR? Considering that these maps that we're using here, this is on norepinephrine. Okay, so to calculate the SVR, we use this formula here. So it's his maps. So his map is 56, the mean arterial pressure, minus the CVP times 80, okay? 80 is just a constant, and then you divide that by the cardiac output that we calculated here. So it's 56 minus 6, which is his central venous pressure, divided by his cardiac output, and we're going to have a number of 727 dynes per second per meter square. Normal would be, I mean, there are some variations here, depending upon where you guys look, but usually the normal range is somewhere between 800, 900 being more conservative, to 1300, or sometimes people consider even 1500 kind of normal. Okay, but clearly he's down. His systemic vascular resistance is decreased. So again, this is a distributive shock. Okay. Any questions so far? Are you guys following?
Yeah.
Okay, cool. So this is just a table with normal hemodynamic values. You guys need to memorize this. I mean, some of these numbers here, you need to have in the back of your head, just like sodium and potassium levels. So SpO2, it's usually ranges between 60 and 75%. Stroke volume, stroke index don't bother much, but cardiac output, this is the normal cardiac output, between 4 and 8 liters per minute. Cardiac index, you're going to see later, that this is really important. It's an important number for you guys to memorize, around 2.5. MAPS, you guys know. CVP, central venous pressure is usually, less than 10. And these are, some numbers. This is the number for the SVR and numbers for the PA pressures. Okay. So going over, point of care ultrasound, I was talking about some of those views, and here I'm just going to get into more detail. Okay, so since this is going to be recorded, you guys can always go back to these slides and review some of that. Okay, so as a resident, you guys need to make sure that you're able to get some basic views, okay, to assess some major structural abnormality. I mean, you're not going to it's not like a full echo, it's just you guys are just trying to see if the heart is squeezing well or not. Do you have pericardial, a significant pericardial effusion, or do you have something really major kind of going on with the heart? So it's pretty much telling if the heart is funky or not. So these views, especially the left part sternal view, and here if you orient the ultrasound in this axis here, you're going to have the parasternal long axis view. If you just turn the probe about 90 degrees, pointing to the left shoulder instead of the right shoulder, you're going to cut the heart tomographic, those kind of tomographic images. So you're going to have a parasternal short axis. Okay, and then if you put the probe here, usually facing down, okay, this is a few intercostal spaces below the nipple. You're going to have the apical views and the subcostal views. It's really important for you to assess the intravenous, the IVC, the inferior vena cava. Okay, so this is for you guys to get a better grasp. Okay, so this is what they call the Plax view, that is short for parasternal long axis view. It's the major view of the heart. Okay, so this is the same that you saw earlier. So here you have a piece of the RV, that's the right ventricular outflow tract. Okay. So depending upon how you angulate the probe, you might even see the pulmonary valve rising here. Remember skull and crossbones, right? So the pulmonary valve is anterior to the aortic valve. So you have the RV, that is the most anterior structure here. You have the interventricular septum here. You have the left ventricle cavity here. You have the LVOT, or the left ventricle outflow tract, the aorta. you have the mitral valve, the anterior leaflet, okay, the posterior leaflet, and then you have the left ventricular posterior wall, here. So this is like a very basic, it's like the first view, the first, thing that you get. So if you turn the probe like 90 degrees, as I told you, depending upon where you're gonna cut, you can cut the probe like, at the base, and here you're gonna see like the Mercedes-Benz sign, here, the aortic valve, and the most posterior structure you're gonna see here is the left atrium. Anterior, you're gonna have the RV, more precisely the RVOT, or the RV outflow tract. Pulmonary valve, you're going to see the PA. You're going to see the right atrium here, on the aortic level. This is usually like in a more challenging view. It's more like fellow level. But this, if you go down, you're going to cut the ventricle, the heart, in the level of the mitral valve. And here you can see like, the anterior leaflet, the posterior leaflet. You're going to see like a fish mouth here, okay, just as you can see. And this lid here, this is the RV, okay? And note the septum here. The septum usually bulges towards the RV. If you have something like a pulmonary embolism, as you're going to see later, the septum usually becomes like a D, like a D-shaped. This is where you see like the G-shaped septum, So that's another thing, that you can see. If you're concerned about pulmonary embolism or PE, this is a really good view, for you to take a look and see how the RV is. Here, you go down further, you're going to see the papillary muscles, okay? And you see like the posterior, the posterior medial, the anterolateral, and the posterior medial is important because it's only supplied by the RCA, okay, by the right coronary artery. If you have like an inferior MI, the only supply that it gets, from the RCA, can go down, and then you can have this papillary muscle here not moving well, and then you're gonna have this posterior leaflet here is gonna be stagnant. So you're gonna see like lots of mitral regurgitation, with inferior MIs. Okay, and this is the apical 4-chamber view. This is putting the probe just below the nipple, okay? You're gonna see like the LV, the left atrium, the right atrium, interventricular septum, interatrial septum here, the tricuspid valve, okay? And if you angulate the probe a little bit upwards, you're gonna see the aortic valve here. This is the apical 5-chamber view, okay? And if you turn the probe like 90 degrees, you can get the apical 2-chamber view. Okay, so you're gonna see like the aortic valve, the left atrium, left ventricle. Okay, so this is a little bit more kind of advanced. I want you guys to focus on the apical 4-chamber view. This is really important, especially if I talked about PE. So here, that's when you see like those huge RVs that patients that have massive Ds, they're gonna develop. Okay. And subcostal view, sometimes, patients, they are intubated, they have a bunch of stuff, going on in their chest, and sometimes you don't get good windows. And usually, the subcostal view is one of the most consistent. So here, you see like, the RV, it's more anteriorly to the RV, you can see that there's like a collection of fluid here. There's this pericardial effusion here, the RA, the LA, the LV, okay? And if you go down a little bit, if you angulate our probe down, you're gonna see the inferior vena cava here. Just putting like, the M mode, you can see that the patient, whenever he sniffs, the IVC, it tends to collapse. In this case, it doesn't collapse. So the IVC, it's really important for you guys to assess the fluid status of the patient, right? So if the patient has congestive heart failure, has lots of fluid on board, okay, so the IVC will be huge. If not, if they're dry, just like as we had in our patient, the IVC would be collapsible. Okay, so this can answer like a really important question: does this patient needs fluids, or does this patient needs diuresis? Okay, so this is something that can help. Okay, and this is how you estimate the right arterial pressure. So remember that the patient had. So this is a view of the IVC, the subcostal view, just like as I told you. getting connected to the right atrium. This is the hepatic vein. So you just measure the size here, and the size, normal size would be below 2.1 centimeters. Okay, so if it's greater than 2.1 centimeters, you're gonna see also if it collapses with inspiration. Just ask the patient to sniff. You ask the patient literally, can you sniff? And the patient sniffs, and you see after he sniffs, you see that there's a collapsibility. So this patient, he might, need some fluids, okay, if he's hypotensive. And here, this is based on the guidelines, on the 2015 guidelines. Low IVC size, less than 2.1, with great collapsibility. By definition, this is based on a bunch of studies. I mean, there's lots of loopholes here, but for the most part, it helps for you to estimate the pressure. So it says that the artery pressure, which is the same as the central venous pressure, is low. It's 3. If there's any kind of intermediate combination, you consider 8. If it's engorged and if it's not collapsible, you consider the artery pressure to be 15. Okay. Are you guys following so far? Any questions so far?
No, it's great.
Okay. Are you guys following all of those echoes and stuff?
Yeah.
Yeah.
Okay. Good. Okay. So now we have another patient. Okay. So he's a 50-year-old guy. He presents with months of fatigue and dyspnea. His echo show markedly decreased left ventricle ejection fraction, as you can see below. And he had frequent episodes of non-sustained VTs. His blood pressure is 180, which has been limited by medical management. And then we can see here, this is the same thing, Plex view, personal long axis view, RV. You have interventricular septum here. You have aortic valve opening here. You have the, the mitral valve. You can see like some chordae here. So what do you guys think? This is the apical 4-chamber view. What do you guys, which of these options, I'm going to give you guys 3 options of ejection fractions, okay? So which one do you think it is? So option A, 50%. Option B, 40%. Option C, 15%. What's A, B, or C? 15%. Yeah, really, really low. Okay, barely moves. So this is heart failure, right? So heart failure, putting a probe, you see how easy it is, put a probe over there. I mean, you can also, do like physical exam, right? But sometimes it's not consistent. You can assess for congestion on the right side. You see if he has leg edema, ascites, all of those classic things. See if there's any signs of congestion on the left side, like part of jugular reflux. Ask the patient if he has orthopnea, bendopnea. That's something that is really important. Not every patient will have orthopnea. You can ask the patient if whenever he bends, to tie his shoes, you can ask him, do you have any shortness of breath whenever you bend to tie your shoes? You're going to be surprised by how many patients you miss saying that they don't have orthopnea, but they have bendopnea, okay? And also you can do like the Valsalva square wave. This is really hard for you to do in a patient that doesn't have an A-line. But pretty much you just, ask the patient to do a Valsalva maneuver. His response would be something like that, A or B. Sinusoidal response or some absent, kind of overshoot, that you would see. But these patients with heart failure, especially left-sided heart failure, they have a square response, of the blood pressure. The blood pressure goes up. There's barely any kind of variation in the heart rate, but the blood pressure goes up, and it's maintained during the different phases of Valsalva. Okay. In a ventilator, if you have a patient, in a ventilator, you can also play with that to kind of an inspiratory pause, and check the A-line. You can see something similar like that. This is more for the boards, especially Leticia and Mateus, is going to do the internal medicine boards, okay? And also, see if the patient has low cardiac output, right? You just feel the patient's chest. Is the patient cold? Does he feel cold, okay? Narrow pulse pressure. If you go back, the pressure of the patient there, it was 100 over 86 or something like that. The pulse pressure, which is the systolic minus the diastolic, was very narrow, okay? very narrow. You're gonna see this, with these patients. And also you can see here, you see how the mitral valve barely opens, it barely opens, because the heart is not moving much. And you can see this, the narrow pulse pressure is kind of a reflection of that. Everything barely moves. Or see if the patient is warm, okay? See if he feels warm. See if he's like, and then you can see, can give diuretics, see if he is responding, to diuretics. Because even if he feels warm, if he's not responding to diuresis, he might have some poor forward flow, or he might have, lots of congestion, okay? Either one, will give, problems to diuresis, okay? Another thing that is really important is this ratio here, between like the right atrial pressure and the wedge pressure, the pressure, the wedge pressure is going to measure the pressure here at the left atrium, okay? You can estimate, the left atrium by just putting a probe here. If the left atrium looks huge, then it means that, the wedge pressure is high. Like in cardiology, we tend to tell that in echocardiography, more specifically, that the left atrium is the A1C hemoglobin of diastolic dysfunction, right? So the patient that have lots of congestion on the left side, they'll have huge left atriums. You can see, if the left atrium is huge. But the thing is that sometimes, the patient might have purely left ventricular systolic dysfunction. And in those cases, they might have a high wedge pressure, but you diurese the patient and his CVP, his intravenous pressure will get low. But sometimes the patient has RV failure. If the patient has RV failure, the central venous pressure will be pretty close, to the wedge pressure. Another thing that you guys see here, this is just this guy, he had an ICG lead here. ICG, it's an implantable defibrillator. Okay, so it's just like a kind of a pacemaker lead here, as you can see. But see this ratio. If this ratio is the right atrial pressure is greater than 2/3 of the wedge, it means that this guy, he might have RV failure, and this is another beast. Patients that have like BIV failure or RV failure, they're really challenging. So you have like a guy like this, so you don't know, do I need to diurese him more? Do I need to give him some inotropes? Cases like that. I mean, it's you see that he has a low EF, yeah, but can we put numbers to that? That's how we get the pulmonary artery catheter. Here you have William Gans and H.J. Swan, who invented the catheter. It has a little balloon here. You implant, in the patient's neck, and it goes up to the distal PA, and there's a little balloon here that after you inflate it, you can get the pulmonary wedge pressure. Okay. And the indications for pulmonary artery catheter are pretty much, patients like that. They have like a hemodynamic picture, patient that you try to diurese, and his creatinine goes up, and you don't know if he's dry or intravascularly depleted. I mean, PA catheter can help, doing diuresis in a patient in a tailored manner with a PA catheter can help. If they have pulmonary hypertension, it's a different beast, RV failure, pulmonary hypertension, or if you're considering advanced therapies like putting a VAD, putting a ventricular assist device, like a mechanical heart, or if like home inotropes, home Mirinon or anything like that. So this is, what happens as you are advancing the catheter. The first chamber, that the catheter gets is the right atrium. Okay, so again, the normal pressure should be something between 2 and 6, and you're going to see those waves here, A, C, V, right? And here, and here you can see the CVP will be you got the peak, you got the valley, and then it's going to be the midline between those two. But what those waves they mean, it's like different phases of atrial contraction. Of course, in a patient on sinus rhythm, right? If a patient has atrial fibrillation, you're not going to see any of these waves. It's going to be more blunted, right? But the A wave, it's the A for the atrium, like atrial contraction. Okay, so you see the atrial contracting here, see the A wave. And then, you know, you have like the X descent, which is like the atrial relaxing, and then, you know, feeling. The tricuspid valve here, you know, is closed. You have like a little C here. That's the ventricle, you know, pushing a little bit, you know, the tricuspid valve, you know, up. And then you have like a V wave, you know, that is exactly, you know, the atrial tense with the tricuspid, you know, closed. You know, you can see that, you know, here. Usually the V wave is not, you know, greater than the A wave. But if the patient has like, you know, tricuspid regurgitation of the V wave, they can have like huge V waves. It's just like, you know, regurgitant, you know, volume, you know, going from the ventricle, you know, to the atrium here. And then from the V wave, you know, we get the Y descent, you know, which is the atrial empty with the tricuspid, you know, open again. And then, you know, A wave, and the cycle goes on, okay? So as you advance this catheter from the RA, and you see on the monitor, you know, these waves here, you know, you see like, you know, the pressure around like 5 or 10 or something like that. And you advance the catheter a little more. This is about like, you know, between 10 and 20 centimeters. After like 20 centimeters, you know, the wave changes, you know, the monitor. You see like those huge like waves. This is the RV waves, okay? So systolic, and then the diastolic, you know, it's pretty close, you know, to 0, okay? And these are like the normal RV, you know, the RV, you know, numbers. You know, usually between 20, 30. Diastolic would be between like 0 and 5. And as you advance it, you know, as you get to the PA, then you're gonna start seeing like this kind of dichrotic, you know, notch here. You know, this is pretty much, you know, the valve, you know, closing. Okay, so it kind of prevents the pressure here, you know, to get further down, just like, you know, the RV. If you have like some incompetence in the valve, if you have a pulmonary insufficiency here, you know, this number here, it should drop. Okay. And as you advance it further, you know, you got your distal branch, you know, of the segmental branch of the pulmonary artery here, and you inflate the balloon, you're gonna start seeing like those waves again that would resemble the waves from the right atrium. So this is the wedge pressure. Those waves here, they should, it's pretty much, you know, the waves from the left atrium being transmitted, you know, back here. So those pressures here should equilibrate with the pressure at the left atrium, okay? So you see like the same thing, A wave, V wave. If the patient has like mitral regurgitation, you're gonna see like huge V waves, you know, here, okay? So far, so good? Are you guys following this?
Yes.
Okay, good. So what's next? So we do what you call like, you know, RHC, or right heart catheterization, okay? And we got all of these numbers. We have the blood pressure of the patient during the procedure, we have the patient's heart rate, you have the patient right atrial pressure, okay, 12. You guys saw here, it should be like between 2 and 6. So this is up, okay? The other number that we get, you know, as we advance, you know, we have like the PA numbers, okay? The mean PA is like 45, you know, this is elevated, okay? Numbers above, you know, 35, you know, these are elevated. So it's like, you know, mild to moderate, you know, pulmonary hypertension. And why are the PA pressures up here, you know, this guy? It's because the wedge pressure, you know, as you can see here, the pulmonary capillary wedge pressure is 30. This number here should be like, you know, below 15. Okay, so it's pretty much, you know, the pressure backing up, you know, the pressure of the left atrium, you know, is so huge because, you know, there's nothing moving forward. The heart is stiff, you know. Remember that by definition, if you have systolic dysfunction, by definition, we have diastolic dysfunction as well. So the left ventricle is not compliant, you know, the guy, for him to keep his blood pressure up, his blood pressure normal, his intracardiac pressures, you know, need to be super high. So this is a really high wedge pressure, and it's backing up, you know, to the lungs, okay? How do I know if this is just, you know, the pressure backing up to the lungs and not, you know, some kind of primary pulmonary hypertension? I do something that we call TPG, or transpulmonary grading. I get this pressure here minus the pulmonary artery mean pressure, and this number here should be like, you know, below 15. Okay, so for him, it's exactly 15. It's right there. Okay, but I mean, this is a guy that he doesn't have pulmonary hypertension. Okay, it's pretty much what you call post-capillary pulmonary hypertension. You know, it's because of pressure kind of backing up, you know, from the atrium. Okay, And then we calculate, his cardiac output, and his CI based on central venous sets. Okay, I didn't put it here, but we can get like central venous sets, and then we can calculate just like as we calculated for the other patient. I just give you the numbers. Okay, and based on these numbers, the cardiac output and blood pressure and RA pressure, you can calculate his SVR. His SVR, remember the normal SVR, we usually ranges from like 800, 13, 1400. It's 2000 here. It's elevated. Why it's elevated? Because in poor forward flow, over time, you have like activation of the RAS system, have activation of the adrenergic system, so he's vasoconstricted, okay? So the SVR is super high, okay? The pulmonary vascular resistance here, 400, I mean, it's a little bit elevated, not that high. And this is a stroke volume, so with every beat, he puts out about, 30 cc's, okay? So remember, cardiac output is 3, right? So if you multiply systolic, the stroke volume here, 30 times his heart rate, you're gonna get exactly, the cardiac output, okay? So with each beat, he puts out 30 cc's. He has 100 beats in 1 minute. So multiply them, then you have like 3 liters in 1 minute. Okay, so cardiac output is equal to heart rate times the stroke volume. So here, his cardiac index, okay, for his body, I mean, a cardiac output of 3 liters might be fine for somebody who's really small. But the guy, I mean, based on his BSA, his CI is 1.5. So where do I put this guy? Okay, so here, I don't know if you guys have seen this, but it's pretty classic, for heart failure patients. We have those quadrants here. So if the patient has low cardiac output, based on the cardiac index of 2.2, sorry, if he has like a normal cardiac output, greater than 2.2, and he has a low wedge pressure, okay, so he's in the quadrant of normal, okay, so his left-sided pressures are low, and his heart is squeezing well. So he's not congested, he's normal, okay? So if he has normal cardiac index, but his wedge is high, he can get congested, he can get, pulmonary edema, if those numbers, get really high. But he's gonna be warm, and wet. Here, he's gonna be warm and dry. This is normal. This is warm, okay, because his cardiac index is normal, and wet because his wedge is high. What if, his cardiac index is low, okay? So, he might be dry if his wedge is less than 18. So he might be like a little hypovolemic, and so he's cold and dry here. So this guy that is cold and dry, he might benefit from a little bit of fluids, right? But this guy here with cardiogenic shock, he is by definition has a low cardiac index and has a high wedge pressure. So he is cold because the index is low, and he is wet. He's cold and wet. See? So it's 18 and 2.2. So he is cold because his CI is 1.5, and he's wet because his wedge is well above 18, okay? So what does he need? So he needs diuresis, okay? So he needs to, we need to diurese this guy because his heart that is really engorged, that is really dilated, after we diurese him, we can get his heart size, to get smaller. And if you remember the Stalin curve, we can dislocate him to the left, okay? So we can make him go a little bit, to the left and get like a more optimal, cavity size. In Brazil, there was like this guy, this crazy cowboy surgeon called, Randas Bandeira, I believe that was his name, in which he would like, cut apical aneurysms, of patients with heart failure. And the patients would get better, he would like decrease the size of the ventricle, and well, like, different mechanisms. It's more like, Laplace's, law, but whatever. You get to more kind of optimal point. But this is usually insufficient, okay? So you need to diurese him, but at the same time, you need his heart to kick a little bit more harder, okay? So what do? So we use inotropes, okay, for that. So it's usually dobutamine, which is a pure, beta agonist. But the problem with dobutamine is that it lasts a couple of minutes. If we stop a dobutamine drip, a couple of minutes away, and then the heart goes back, to baseline. So we try to use mirinone. So mirinone is great because mirinone doesn't act on the beta receptor; it acts downstream, and it increases the amount of cyclic AMP. So it's downstream to the receptor. And it also causes vasodilatation, okay? So remember that the patient here has a really high systemic vascular resistance. So the heart is already weak, but at the same time, it has to overcome a huge amount of resistance. So with mirinone, you can achieve all of those two things. You can decrease the SVR. It's a really good vasodilation. You see this happen wonderfully in patients in the CCU after we start them, mirinone. SVR goes down and the cardiac output, cardiac index go up, okay? You can also try some vasodilators, sometimes. So you can try nitroprusside, okay? So nitroprusside is, you can titrate that, sometimes you just need to be careful, especially in patients that have AKI, that have acute kidney injury, because they can have cyanide poisoning. But you can use, vasodilators, in these patients as well, if you're really careful, if you monitor the pressure. And you can transition these patients to more long-acting forms, things like Bidu, for instance, things like ACE inhibitors, they act as kind of vasodilators, right? And now we have Entresto, sacubitril valsartan, which it's a great vasodilator, right? So you can have all of this. The other thing, that you can do, like diuretics. Okay, so loop diuretics, of course. Loop diuretics doesn't work by themselves. Then you add sequential nephron blockade. You do like furosemide plus diureal, which is chlorothiazide. So you have two diuretics working together, to have the patient to diurese more. You can also try to use SGL, T2 inhibitors. These are a new kid on the block for heart failure, empagliflozin, for instance. So the patient will pee more. Even patients who have normal A1Cs, they benefit from that. So we have all of these new kids on the block, and you guys need to be, knowledgeable about these things because you're going to see a bunch of heart failure. Okay. If these things, they don't work, then you need to start thinking about mechanical support, things like balloon pump, things like Impella, or long-term like a VAD or heart transplant. Stage D heart failure patients, they eventually they will need a transplant. Okay, unless they have some contraindications for that. Are we following here?
Yes. Can I ask a quick question? What would be the drug of choice then between dobutamine and mirinone? Because you do have the vasodilator effect in both of them, right?
Yeah. So on the long run, because the patients, they go home, they get a PICC line. Okay, they have a PICC line is for the people who are not familiar with that. It's kind of an IV line that goes. So it's a tube that goes into your peripheral IV. But it can stay there, it can stay there for like months. Okay, so the patients, they go home with a drip, with a mirinone drip. So we try, to go for mirinone, as we can. However, there are patients that have, patients on dialysis, for instance. It's using mirinone. You can still use it, okay, but it's trickier because mirinone is not dialyzable, so it can get accumulated and people can have toxicity, from that. It's usually in the form of arrhythmias. And so in that case, the dobutamine, might be, the case. The other problem is insurance, right? So patients, dobutamine is super cheap. But if you have, some patients that, they require some home inotropes, and if they don't have insurance, then dobutamine might be like another way to go because otherwise they wouldn't be able to afford it. In dobutamine, they have some ways of getting it, for free through some programs or whatever. So there's things like that. Ideally, you go, with mirinone. Mirinone is a better, drug. The other thing that is good about mirinone is that it lasts hours. So it's very common, you know, for patients to go home and they're home and bad things happen, you know, to their pump or to their PICC line. So if they're like on the butamine, if they live like 2 hours from the hospital, if they have a problem with the pump, a pump failure, and they need to go to the hospital to have that exchange or whatever, in a couple of minutes, you know, the effects of the butamine, they will go away. But if they have Mirinol, after they stop the pump, you know, it lasts several hours, so they can go back to the hospital. They're not going to be in cardiogenic shock. Does it make sense?
Yeah, it does. Got it. Thank you.
Okay, good. So this is it, you know, for the cardiogenic shock. Okay, so pretty kind of a classic case. So here, it's another case. This is a real case. And this is a 66-year-old guy, had chronic pain syndrome. He presented, you know, at some point from OSH's outside hospital after witnessed PA arrest. PA means pulseless electrical activity arrest. So he was with his grandson. He suddenly collapsed, and the son witnessed, started CPR. They call EMS, which is the paramedics. He received Narcan, which is naloxone, and he became alert. They did a urine drug screen. Never forget. I mean, these guys that come, you know, they are like, you know, altered. Always get a urine drug screen. It's super easy, and then, you know, can screen for a bunch of drugs like benzodiazepines, opioids. You know, here in this country, unfortunately, we have an opioid crisis. So his urine drug screen was positive for benzos and opioids. So in the AD, they also found that his that he had some lactic acidosis and acute kidney injury, or AKI, thought to be related to the OD. OD is overdose. So he was set to be discharged when he again had another LOC, means loss of consciousness. And he was found face down in the exam room in a pool of blood. He became unresponsive, requiring immediate intubation. So this was like, you know, the original EKG. So the outside hospital, they were concerned about those T-wave inversions here, you know, V1 to V3. They thought it was like, you know, Wellens-like, you know, waves, you know, Wellens syndrome, you know, the proximal LED, you know, obstruction. So they were like really impressed, you know, by these. They got some labs, you know. So here you need to know how to be familiar with the fish bones. Okay, so here, you know, the fish bones. This is for the CBC, complete blood count. Okay, so here you see WBC, or white blood cells. Here you have hemoglobin, and that is above hematocrit. Okay, and here you have platelets. Okay, so this X here, it's always that white blood count, hemoglobin, and platelets. In this fishbone here, this is for what we call BMP, a basic metabolic panel. First, sodium, potassium, chloride, CO2 or bicarb. We have BUN, which, you know, for Brazil, you know, BUN would be like urea, you know, something equivalent, you know, to urea, you know, in Brazil. But here we don't get urea, we get BUN. His creatinine and his glucose, okay? We have troponin I. People don't get CKMB here. Nobody knows what the heck is CKMB. They get troponins, which is superior. And his first troponin was negative, and the second troponin was high, okay, less than 0.03. This is the low threshold for so it's negative, and then a repeat one a couple of hours later was high, was about 3. Lactate was elevated, it was 2.7. So he was kind of in shock here, and they thought it was cardiogenic, you know, due to this. However, look at his bedside echoes, okay? Look at this. What do you guys see here? So apical 4-chamber view, okay? We have the 4 chambers. This is the one, just reminding you, below the nipple, okay? So we have LV, left ventricle. You have the RV. Look how huge the RV is. This is the right atrium. This is the left atrium here. So look at the ratio. The RV is almost like twice the size of the LV, the poor RV. And here it's a personal short axis view, a cross section. You know, this is at the level of the papillary muscles here. See, the letter D here, that's a D-shaped septum. The septum should be like bulging to the RV. The RV is huge. It's huge. It's kind of encroaching here, the poor, LV. And after the patient takes a deep breath, remember that your IVC or inferior vena cava is like a straw. So if you take a deep breath, there's negative pressure inside of your chest. And you're going to get more preload here to the right side. So with more preload, the septum will bulge to the left, and it's going to decrease, the left ventricle size and the cardiac output, So every time you take a deep breath with a ventricle this big, the left ventricle, will get less preload, okay? And with that, the cardiac output will go down. And with that, the pressure will go down. This is a classic, pulsus paradoxus. This is, what we see. And there's like, different ways, of demonstrating that. Most common way, is putting a blood pressure cuff, measure the blood pressure, asking the patient to take a deep breath, and then, kind of measure again, and you'll see it drop, okay? So this is huge. The other thing that you see here, well, here you don't see that, but sometimes whenever the RV gets engorged like that, sometimes, the lateral wall here, doesn't move much, just like, the apex, move. This is what they call like the meconal sign. So the meconal sign is something that is classic, for PE, for pulmonary embolism. And here, I'm going to talk to you more in more detail about that. So they put like, some color Doppler here. There's like, some blood going from the RV backwards, to the right atrium. This is because, the tricuspid valve, it was made, to be incompetent, okay? So after it's tri-leaflet, has 3 leaflets, so lots of, space there for, lots of room there, for flow to go backwards. So there's like some flow here coming backwards, and here you can you see like a continuous wave, Doppler. So everything that is down is going away from the probe. So you see this line here, that's just, continuous wave measures velocities all across, this line here. If you have pulse wave, it usually has a box and it just gets the velocities at the sample, where you put the sample. But here it's continuous wave. So these velocities here, they are going away from the probe. So these are negative here. And you can see like the Tmax here is 4. And if you do like the modified Bernoulli equation, the simplified 4v squared, 4 times v, which is a velocity square, velocity square 4 square is 16. 4 times 16 is 64. This is just like, the gradient, between the right atrium and the right ventricle. The gradient here is 64. So the pressures inside of the right ventricle, they're really, really high. Okay. The other thing is that you can estimate the right atrial pressure by checking the IVC. The IVC here is 3.2 centimeters. Remember that the normal would be below 2.1, super enlarged, and it's not collapsible. So, the estimated right atrial pressure would be like 15, 20. So you can add like, 15, 20 times, the gradient here. Okay. So the pressure here is 20 times, plus the gradient that is 64. So you're going to have the RV pressure, the RV systolic pressure, of 84, here almost, okay? It's almost systemic levels, okay? And you can see this with just like, putting an echo probe, on a patient. And this is after the patient was transferred, to us. You can see here, the echo is kind of, low voltage, but you can see that he has, S1, Q3, T3, which is a classic, strain pattern. There's also, some, you don't see like, other, but, you see like sinus tachycardia, which is really sensitive, for PE. You see like, the RV strain pattern here, so you see like this echo, and it was like, okay, so what does this guy have? So you can check, here. So he got CT abdomen pelvis. There's a bunch of, junk here. It's just like, some atelectasis, some, lots of, atelectasis, here. But, we're not focusing on this. You see like how bright it is. This is a contrast study, it's pretty much under the color of the bone here. This is a mediastinal window, that's why the lungs are all black, okay? And then after we go down here, you can see this gumba here, this filling defect here. It's a huge, huge clot, over there. You can see on the other side as well. You can see some, filling defects here. Here it's more, it's harder, for you to see because of all of, the atelectasis associated, with that. But you see, like, some huge PEs over there. And then down here, you can see, like, the ratio of the right ventricle, it's greater than 1. The RV-LV ratio is, like, greater than 1. It means that the RV is bigger than the LV. It should be the opposite, okay? So he ended up getting some venous Dopplers of his lower extremities. Why not, right? And he had some distal right femoral DVTs or deep vein thrombosis. His CT had showed no sign of intracranial hemorrhage, and this is important because he got TPA, which is alteplase. So he got thrombolytics, and then he was transferred by air, bleeding, blah, blah, blah. So the PER team, that's the PE team. So, we saw, and the thrombus was like, it's organized. Probably he's not, going to get any kind of percutaneous embolectomy or whatever. Then we saw, like, CT surgery, and they were like, well, maybe this guy, needs some echo, so we can temporize him, and then we can probably do, like, a surgical thrombectomy. It was not a surgical candidate, at the time. So he was, like, intubated. People, they do, like, some Flowland, which is prostacyclin. Inhale prostacyclin, to see if they can open up, their blood vessels, decrease a little bit of, the pulmonary pressures. He was kept on dobutamine in 3 pressors. So dobutamine here, it's mostly for RV support, okay? It was aggressively diuresed, he was extubated, and then he was put on non-invasive positive pressure, okay? Airvo, which is high-flow nasal cannula. It was alternating between high-flow nasal cannula and BiPAP. Got some ICU delirium and blah, blah, blah. He was unable to be weaned off, of epinephrine, and on serial TTEs, transthoracic echocardiograms. He had severe, persistent severe RV systolic dysfunction, severe RV enlargement, with the ratio greater than 1. His estimated right-sided pressures were huge, like in those systemic levels. So he was... he ended up, getting mechanical thrombectomy. And here you can see, the white clot. This is like more old clots. TPA doesn't work here. TPA works. There's a little bit of fresh clot, but there's also, some white clot here that is chronic. TPA works wonders here, but he probably had some kind of chronic clots in it before, and it didn't, work. And that's why, after he got mechanical thrombectomy, I mean, he was, started on Coumadin and, all of that. And this is, him, like before, with RV systolic pressures, almost like, at systemic levels. And this is after, he got thrombectomy. See the difference between the right ventricle here, okay? It's remarkably different. Okay, remarkably different here. Here, you can see the RV, like, taking most of the apex. And here, it's like a more normal looking one. You see, like, how the septum, bulges to the side. It kind of indicates that the pressures here are super high. That's why it's like encroaching the left ventricle. And every time this happens, it's less stroke volume here and less cardiac output. So the pressure drops, so you have pulsus paradoxus because of this, because of this, what they call like the septal bulging here, okay? And one thing that I wanted to call attention here is how you estimate the right ventricular systolic pressure, okay? So as I mentioned, we use like 4V squared. That's how we convert velocities, because Doppler pretty much, it measures the ultrasound. It's a sound wave, okay? A hypersonic, ultrasonic, sound wave, that goes here, and it's reflected, in the structures of the heart, including, the red blood cells. So the red blood cells, they're like moving. If they're moving like towards the probe, the frequency goes up compared to the frequency that it was reflected. If they're going far away, the frequency gets down. So it can tells you where, the flow is going. So here, you can see that the probe is here. Anything that is red is going towards the probe. Anything that is blue is going away from the probe. And here you see some, what they call like aliasing, whenever there is like some turbulent flow here. And in this case here, this is a patient that has, I showed you before, this echo. It's a patient that had an ICG lead here, and there was some, tricuspid regurgitation, okay? And if you put like the continuous wave Doppler here, we can see like the jet, of the tricuspid regurgitation, and we can get the velocity and use 4V square, to estimate, the pressure. And we get the pressure is pretty much the gradient between like those two chambers, the right ventricle, that is the high pressure, chamber, and the right atrium, the lower pressure chamber. Okay, so we have like the gradient here. So if you have the gradient here, if we add the right atrial pressure, then you can have the right ventricular systolic pressure here. And as I mentioned to you, whenever we have we can get subclassical views, and then we get the IVC. We measure the IVC. In this case, it's 2.5 almost, which is greater than 2.1. And then we ask the patient to sniff. We see that it's not collapsible. So in this case here, we have an estimated right atrial pressure of 15, by the tables that I've shown you, right? So in this case here, if I put continuous wave Doppler here, it's velocities, it's around like 3, 2.9. So doing 4V squares is like 33. So 33 plus 15, from here, it's 48. So mildly elevated. Okay, so there's like some mild pulmonary hypertension in this particular case that I show here. Okay, I think there's like a last case here. I think this is more. I'll leave. I'm not going to talk about this. This is more it's more like cardiology, first year cardiology fellow level. I'm going to leave this away. But I think that we pretty much cover most of the things that a resident needs to know in terms of hemodynamics. Okay. I'm going to stop sharing the screen. Leticia, you can stop sharing you can stop recording.
Sure. I'm just going to say thank you very much and say that Simonato is very upset that the last case is going to be skipped.
And as we can see here, it all comes down to imaging. So that's why everyone should do imaging, right?
Okay. Yeah, I'm going to stop the transmission right now.
Okay.